So, case study infertility in PCOS patient. This particular patient is of 32-year-old female visiting for evaluation of infertility and menstrual irregularity. Can you see this screen, please? I just want to confirm it.
Yes, sir. Yes.
Okay. Yeah. And she was married for 12 years and her BMI was 28.72. History of abortion after 2 years of marriage, and for last 6 months she is oligomanic, for last 8 years in period of amenorrhea for last 6 months. She is having significant hirsutism, modified Ferriman-Galvis score of 8, no sign of acanthosis, no other systemic abnormality. She has been taken ovulation induction drugs so many times, but she was failed to conceive. So on lab investigation, husband semen analysis was normal, and all other routine parameters were normal except for the fact that LH-FSH ratio was high and testosterone was high. On USG, it was going in favor of PCOM, polycystic ovaries, with significant enlarged ovaries as well as tiny follicles seen in the periphery of ovaries. So secondary amenorrhea with hirsutism together with the appearance of polycystic ovaries on ultrasound established the diagnosis of PCOS. So before going to this particular patient, I'd like to overview of PCOS. It's a common heterogeneous heritable disorder affecting women throughout their lifetime, characterized by the hyperandrogenism, ovulatory dysfunction, and polycystic ovaries. Common finding includes insulin resistance, hyperinsulinemia, which increases the risk of diabetes and cardiovascular disease. Since the topic itself saying that PCOS from an endocrine perspective, so I like to highlight those particular parameters or abnormalities in PCOS, which is it's a syndrome where not only the ovary is at risk, but other biochemical and endocrinological and metabolic abnormalities are there. So just to share the background, initially it was found that estrogen level they recognized that hyperandrogenic complaints like acne and hirsutism were having a significant association with the ovarian dysfunction. And once they had the wedge resection of ovary, they found that there was drastic improvement in the hyperandrogenism. So it was found that primary culprit is probably ovary. So it was considered as polycystic ovarian disease. But after research and after so many studies in this particular disease, we have found that varied degree of endocrine and metabolic disturbances were also seen along with the ovarian dysfunction, and even without ovarian cyst and even without ovarian ultrasonic feature or polycystic ovary, these abnormalities were there. So that is why it is now labeled as polycystic ovarian syndrome, PCOS. As we know that PCOM is another term which we use, especially in those patients who are having these ultrasonographic finding where 20 or more follicles in at least one ovary, measuring 2 to 8 or total ovarian volume more than 10 cubic centimeter. Diagnostic criteria of PCOS, there have been like efforts since 1992 where the National Institute of Health and National Institute of Child Health and Human Disease, they gave the diagnostic criteria where they have, after excluding the other androgen axis disorder like congenital adrenal hyperplasia, adrenal tumor, or other disorder which leads to androgen axis, all these criteria should be met whenever we are trying to diagnose a patient of PCOS. One is clinical or biochemical hyperandrogenism. Second is menstrual dysfunction. But after over the year, European Society of Human Reproduction and Embryology and American Society of Reproductive Medicine, they gave the criteria which are also popularly named as Rotterdam criteria in 2004. After excluding all other causes of androgen axis, they gave that there should be at least 2 in the 2 out of 3. These one is clinical or biochemical hyperandrogenism, second is oligo-ovulation or anovulation, or third is polycystic ovaries. The problem with this Rotterdam criteria was that after having this criteria in consideration, there was almost from 4 to 6% of PCOS inheritance earlier incidence, this incidence increased to 21%, which was found observed by Coop et al. So why it was happened? Actually, they considered two phenotypes as per this definition. One was non-hyperandrogenic, where oligo-ovulation and polycystic ovaries on ultrasound were taken into consideration. And another group was polycystic ovary with hyperandrogenic, which was considered as ovulatory phenotype. So this Rotterdam definition was having this problem that significant increase in the incidence of PCOS was there after consideration. So because of that, in 2008, Androgen Access Society and PCOD Society, they gave the criteria that before considering PCOS as a diagnosis, we should have one clinical or biochemical hyperandrogenism, one criteria, and secondly, ovarian dysfunction and or PCOS. That means even if you are not getting ovarian PCOM in patient, but patient is having ovarian dysfunction, then it should be considered as PCOD. So the purpose of this particular discussion is that whenever we are considering a particular criteria to diagnose as PCOD, we'll have to consider any condition which is having biochemical and clinical hyperandrogenism. This is very, very important component along with the ovarian dysfunction to make a diagnosis of PCOS. As I said, PCOS is having two phenotypes. If you can see the three limbs are there. One is hyperandrogenism, second is oligo-ovulation, third is the morphological changes. So classical PCOS is that which is having all three components. And another phenotype is non-hyperandrogenic phenotype, where there is no hyperandrogenic component. And why I am considering this, that classic PCOS is having more association with insulin resistance and metabolic abnormalities, rather than the non-hyperandrogenic phenotype, which is having lesser association with insulin resistance. So I am coming to the main part of PCOS as far as endocrine is concerned, that is insulin resistance. Approximately 40% of the patients with PCOS, even up to the level of 70 to 90% obese PCOS and 30 to 75% of the lean PCOS have some degree of insulin resistance, which probably contributes to the hyperandrogenism PCOS and also considered as a pre-diabetic condition whenever we are taking history of diabetes possibilities in any patient. And if patient is having history of PCOD, that goes in a significant family history, significant past history in terms of risk of the diabetes. It is also associated with the lower adiponectin level, a hormone secreted by the adipocytes and regulating the lipid and glucose metabolism. So what is the impact of insulin resistance as far as endocrinological disturbances in PCOS is concerned? Insulin resistance or increased level of insulin, they lead to changes in hypothalamic pituitary ovarian axis by decreasing the hepatic sex hormone binding globulin production, increasing the ovarian androgen synthesis, and increasing the LH-FSH ratio. In turn, because of the increased androgen level and decreased SHBG production, it leads to hyperandrogenemia, and which in turn leads to oligo-ovulation or anovulation, and which is a most important component as far as polycystic ovarian syndrome is concerned. So the core issue in PCOS is insulin resistance leading to hyperandrogenism, and this hyperandrogenism is leading to peripheral resistance of the insulin. So they complement each other, and ultimately, because of the hyperandrogenism, it leads to ovarian dysfunction and leads to infertility. How to establish that patient is having insulin resistance? There are three parameter where we can demonstrate or document the insulin resistance. The most commonly used is HOMA-IR model, where by just measuring the fasting glucose level and fasting insulin level, by a simple formula, we can calculate the score, and score less than 2.5 is normal. And if it is more than 2.5, and especially if it is more than 4, that is clinically significant. It's a very simple, minimally invasive, predict fasting steady state glucose and insulin level. Only disadvantage with the HOMA-IR is the insulin sensitivity in subject treated with the insulin needs further validation. And another two formulas are also there. One is Quickie and Mastuda, and which are having almost a similar efficacy or predictability as far as HOMA-IR comparison is concerned. So infertility in PCOS is because of the certain things which I would like to highlight. The most importantly, PCOS is most common cause of menstrual irregularity in young females especially. Process of oogenesis seen in patient with PCOS is different as compared to normal cycling fertile women. LH as well as insulin are especially significant to PCOS patient, as almost up to 60 to 80% of cases they exhibit some amount of insulin resistance, which might contribute to the increased level of insulin. This increased level of insulin in ovaries enhances the ovarian theca cell response of LH, ultimately leading to the excess of androgen at that site. Decreased FSS relatively to the LH level, it decreases the estrogen level and consequent anovulation. And hyperinsulinemia also leads to the increased plasminogen activator inhibitor 1, PAI1, which is risk factor for the intravascular thrombosis. All these changes leads to infertility some way or other. Hyperinsulinemia particularly interferes with the embryo implantation. Insulin resistance can lead to miscarriages due to inadequate nutrition and support of growing embryo. And of course, there is a risk of gestational diabetes during the pregnancy. So overall complication of PCOS across the lifespan, not only reproductive but metabolic are also there, as we have discussed. So because of insulin resistance, and the core issue is insulin resistance, which leads to all these ovulatory dysfunction as well as metabolic dysfunction. So these are the comorbidities usually seen in PCOS patient and should be analyzed in every patient which is considered to be a patient of PCOS, where obesity, insulin resistance, metabolic syndrome, hyperlipidemia, cardiovascular possibilities. In obese PCOS, especially sleep apnea, endometrial carcinoma, depression, anxiety, infertility, they are the most commonly seen comorbidities. Metabolic syndrome present in almost 1/3 of the women with PCOS. And it's a vicious cycle that insulin resistance leads to PCOS associated with abdominal fat deposition, turn leads to insulin resistance. So this hyperinsulinemia and obesity are associated with increased risk of dyslipidemia, diabetes, and a major contributor to the cardiovascular risk. So whenever diagnosis is made after considering a parameter which we have discussed, we should work up in terms of other metabolic disorder, like we should look for hypertension and obesity by calculating BMI, and dyslipidemia, and of course dysglycemia. We have to see and look for the possibilities of gestational diabetes in the next conception. And of course, if patient is having sleep apnea, then we have to do sleep study, and we should screen for depression and anxiety. So any patient who is having PCOS and trying to conceive, preconceptional counseling should be promoted. And this lifestyle, other than lifestyle modification by losing weight prior to ovulation induction, it is shown to improve outcomes. So as an endocrinologist perspective, I like to say that just alone ovulation induction is not going to be very, very effective in PCOS patient, because it just not only the ovarian dysfunction, but it's also carries other things which can affect the outcome of the ovulation induction. Risk counseling, obesity, insulin resistance associated with PCOS increase the risk of gestational diabetes, preeclampsia, growth abnormalities, miscarriages, stillborn rate. So all these things should be discussed with the couple before conception. As we have discussed that insulin resistance, the core issue, so the first line treatment as far as insulin sensitizer is concerned, we all know that metformin is the first line treatment. Metformin should not be used first line for ovulation induction, that's for sure, but controversy still exists regarding the benefit of metformin as far as ovulation is concerned and benefit in ovulation is concerned. But there are good evidences in women with PCOS that metformin along with the clomiphene improves the ovulation and clinical pregnancy rate, but does not improve the live birth rate compared to the clomiphene alone. One randomized control trial showed that pre-treatment with metformin for at least 3 months, followed by ovulation induction agent, increases the live birth rate also. No good evidences to support its use to increase miscarriage rate. Inositol is another agent which I like to highlight in this particular topic, there is a key messenger in insulin signaling system. So theory is that deficiency of inositol is associated with insulin resistance. Though data are conflicting, but meta-analysis from 2018, out of them 10 randomized control trial, 362 PCOS patients treated with myo-inositol and D0-inositol demonstrated that inositol regulated menstrual cycle and improved the metabolic parameters. 2018 Cochrane database systemic review of inositol treatment for subfertile women with PCOS, no added positive effect of inositol compared to standard therapy was demonstrated. Favorable safety profile, minimal no side effects may consider use of inositol. But of course, it's the data, they are not so promising. Vitamin D receptors are present throughout the female reproductive tract. Recent studies have found that vitamin D play a role in follicular development. PCOS and vitamin D deficiency often have similar metabolic features due to their association with obesity and insulin resistance. Studies have shown women with PCOS and vitamin D deficiency were less likely to ovulate and lower live birth rate and higher risk of pregnancy loss. Supplementation may improve insulin, triglyceride, and lower androgen in vitamin D deficient women. So it can be considered because as we see in practice also that vitamin D deficiency is very commonly seen, and those patients who are having infertility and PCOS, they can be considered for vitamin D replacement. Very interesting slide I just added just to share this, that in comparison the fertility in comparison to the tubal factor and PCOS, the fertility improves with the age. And you can see here that tubal factor by age the fertility chances are less. So it's a positive factor that if patient of PCOS, they are treated at any point of time in proper manner, they can have fertility or conception. So my personal, as an endocrinologist, I like to suggest few things for general practitioner, that identify and diagnosis of women, adolescents, especially adolescents with PCOS, is very, very important whenever we are considering infertility. Counsel regarding short or long-term health benefits and evaluate for comorbidities, lifestyle modification to overweight and obese patients. Evaluate patient goal regarding pregnancy and features of PCOS. General, whenever we are considering infertility as far as in PCOS patient, general and PCOS sign specific preconception counseling, as we have discussed, should be done. Evaluate and initiate treatment or refer. Do not wait 6 to 12 months in anovulatory women. Rule out male factor, of course. Supplement vitamin D deficiency and add metformin plus minus inositol in women where insulin resistance is evident, and or those are having high risk category patients. And this have been discussed in earlier topics, but we can initiate with low dose letrozole 2.5 milligram daily. Perform mid-cycle ultrasound if possible to avoid multiple gastration, and if no response, increase the dose. Can consider low dose Globid also. Avoid multiple unmonitored cycle. Women with PCOS have high risk of multiple gestation. Women with PCOS have higher rate of resistance to medicines also. So these are the few things whenever we are considering infertility in PCOS patient, this factor has to be considered. Endocrine Society clinical treatment guideline for PCOS, they say that oral contraceptives are the first line treatment for the management of menstrual abnormalities, hirsutism, acne. Screening for contraindication, those should be done. Exercise, weight reduction is having significant impact on the outcome of PCOS patient. And weight loss strategies begin with calorie restricted diet in adolescents and women with PCOS who are overweight. Metformin as a first line treatment for cutaneous manifestation, prevention of pregnancy complication, and of course for the treatment of obesity. We recommend metformin in women with PCOS who have type 2 diabetes or impaired glucose tolerance, who fail lifestyle modification. For women with PCOS with menstrual irregularity who cannot take or do not tolerate oral contraceptive, we recommend metformin as second-line therapy. Clomiphene citrate or comparable estrogen moderators like letrozole as a first-line treatment of anovulatory infertility in women with PCOS. So All this background, I'm coming back to my patient, where home iron index was calculated by using fasting insulin level and fasting blood glucose level, which came out to be 6.3, which was significantly high. And patient was given, after counseling and lifestyle modification, and of course, metformin and vitamin D supplementation was done with the combined oral contraceptive. And now, in the last, actually, I'd like to conclude my topic by having this two or three slides of discussion. That insulin sensitizer work in increasing fertility is that they lower total insulin level in body as metabolic tissue regains sensitivity to hormone. This reduces the overstimulation of gonadotroph cells in pituitary, and menstruation can be regulated with the oral contraceptive to minimize the risk of endometrial hyperplasia. The progesterone component of the oral contraceptive inhibits the LH secretion and thus ovarian androgen production, and estrogen component increases the SHBG level and thus reducing the free androgen concentration. Weight loss, exercise, lifestyle modification have been proven effective in restoring ovulatory cycle and achieving pregnancy in overweight women with PCOS, and should be the first line option for these women. Our patient was on regular follow-up. After 6 months, regular menstruation was established and 6 kg of weight loss was reduced. And after 1 year, patient became pregnant, and she had uneventful antenatal course and had successful delivery. Thank you so much.